Welcome everyone to this webinar today, which is titled Integrating Psychosocial Supportive Care into the Clinical Management of Short Bowel Syndrome, or SBS. Today is part one, Psychosocial Challenges Experienced by Patients with SBS. And we're brought to you, this program is brought to you by a diverse group of faculty. I'm gonna let each person introduce themselves. My name is Joe Kim, I'm with Q Synthesis, and I will be the moderator at the end when it comes time for our facilitated question and answer. Each faculty will give a short presentation, and then we will have time for discussion at the very end. So with that, let's go ahead and just briefly review the objectives, which are to really dive into the unique psychosocial needs among patients with SBS and their family members, as well as the different reasons why patients with SBS may be at risk for developing significant psychosocial distress, look at the different types of distress experienced by these patients and their families, and explore effective strategies for assessing and managing these types of issues. We're going to outline ways to coordinate care for these patients, and then ultimately look at team-based care coordination strategies. So with that, let's go ahead and turn it over to Dr. Duro. Dr. Duro, if you could unmute and go ahead and begin.
Thank you very much for the invitation to participate in this panel. I'm Dr. Deborah Duro. I'm a medical director First for Children, the Florida Intestinal Rehabilitation Support and Treatment Program at the Sala Foundation Children's Hospital here in Fort Lauderdale. So next slides, please. So this paper just came out now in March, and it's an Aspen position paper for the definition of a pediatric intestinal failure. We know that pediatric intestinal failure is the big umbrella where short bowel syndrome is the main cause of intestinal failure in kids. So is a reduction of the functional intestinal mass below that which sustain life, resulting in a dependence or supplementation of intravenous nutrition, which is parenteral nutrition, for a minimum of 60 days within 74 consecutive days. So this is the new definition right now, the most modern one that we are going to use in the literature. We know that for this kind of situation, long-term PN is the main therapy. And the incidence of kids that develop actually short bowel syndrome is about 42% in children that develop necrotizing enterocolitis. Next slide, please. So here is a better view of the term that goes with short bowel syndrome associated intestinal failure. We know that we can have causes that actually, there is a lack in the intestinal mass, which are due to surgical resections or congenital problems, but also we can have functional decrease in the intestinal absorption. We can go with other situations such as gastroschisis, chronic obstruction, and therefore the better term to use is short bowel syndrome associated intestinal failure. Next slide, please. In this series here of papers, we can see that necrotizing enterocolitis is the #1 cause of short bowel syndrome, followed by gastroschisis, intestinal atresia, and volvulus. But you can have other situations, a combination of both or multiple, and also Hirschsprung disease. Next slide, please. The epidemiology has been increasing lately. We know that to develop surgical short bowel syndrome, you can have 7 in 100,000 live births for neonates have a decreased birth weight of less than 15 grams. And the incidence can even increase further if they are a very low birth weight. In neonates, that can increase by 3% for every 250 grams decrement in birth weight below 1,500 grams. The prevalence of gastroschisis too has been increased in the past few years, from 3.6 cases per 10,000 births in the 1995 to 2005 period to nowadays almost 5% in 10,000 births since 2006 to 2012. Next slide, please. The complications for these kids are tremendous. I mean, they are very complex patients that they can go from mouth problems with oral aversions due to the fact that they need a lot of enteral feeds and many times gastrostomies and also the intravenous nutrition. We can have issues in the different organs like the stomach causing hypergastrinemia and problems with delayed gastric emptying leading to vomiting and reflux. The liver with the problem with IFALD, which is intestinal failure associated liver disease with cholestasis leading to cirrhosis. We can have problems with the gallbladder to the lack of enteral feed, sometimes leading to choledocholithiasis. Those patients can develop a pancreatic insufficiency and decrease also the absorption of fat-soluble vitamins. Due to the anatomical problems, they have resections from the duodenum, jejunum, and ileum, and depending on the area, with multiple vitamin deficiencies, mineral malabsorptions, and other colonic resections that can lead into electrolytes and chronic diarrhea.
Thank you so much, Dr. Duro, for that brief introduction about SBS, as well as all the different complications. And we look forward to the panel discussion with you and the others. So now we're going to allow Dr. Chang to give her presentation. So Dr. Chang.
Hi, everyone. Thanks so much for joining our session today. My name is Shannon Chang. I'm the Director of Clinical Operations at our Inflammatory Bowel Disease Center here in New York City. I want to shift a little bit. So this talk today is more about short bowel, and so the majority of the providers here on the call are going to be more of a pediatric focus. So it's, you know, just a reminder that adults also can have short bowel syndrome, and it takes on a different flavor. But so I'm going to start kind of giving you the adult perspective with this case presentation. So this is a patient who is very complex from a medical and psychosocial aspect. So I'm trying to kind of just set the groundwork for what we might be discussing later in the panel, and give you guys an idea of the adult perspective. This is a 26-year-old man with a history of depression and severe Crohn's disease with a history of multiple bowel resections. Over the last couple years, he has been pretty non-compliant with medical follow-up. He saw his last gastroenterologist 2 years ago, and at that time, the referring physician told me, quote, "This is the sickest patient I've ever seen." Okay, so he comes as a referral to our center and reveals that over the last couple months, keep in mind he hasn't been seen by a doctor in 2 years, has not been on any medicine for his Crohn's disease, despite a history of very severe disease, has lost 25 pounds, which is roughly 20% of his total body weight. He looks severely cachectic and notes severe abdominal pain. As I mentioned, he hasn't been on his Crohn's meds in years, despite recommendations from medical providers. Next slide, please. So we see him, we admit him to the hospital. We want to expedite the workup. He doesn't respond to initial medical therapy. He's started on some IV steroids and is discharged. He is with some improvement. He's supposed to start another medication, a biologic, that he has not tried before, but ultimately before that is able to happen, he has severe abdominal pain, is again readmitted, has a bowel perforation requiring surgery, removing part of his colon, and then requiring an ileostomy. With the ileostomy, which, okay, so his colon is not absorbing at this moment because it's being diverted. His output is above the goal of 1 to 1.5 liters a day. He's putting out 3 liters a day. So ultimately, given that with his severe malnutrition, weight loss, not able to eat because of abdominal pain, he's discharged on total parenteral nutrition, or TPN, for the high ostomy output and with a PICC line for administration. Next slide. At home, he has ongoing very, very severe abdominal pain, is requiring opiates, and is not sleeping very well because his TPN is cycling overnight. And he has to empty his ostomy because it's putting out so much during the night so it doesn't leak. 2 months after surgery, he notes that his left arm, the same side that the PICC is on, is swollen. He calls the office about the swollen arm. We want him to come in so we can examine him. We even want him to come to the hospital, but he lives in a neighboring state. He's unable to come in for an exam or admission because he lives far away. And his father is also caring for his mother who lives with them, who is chronically ill. So he can't leave her to drive his son, and he can't call an ambulance because he lives in a neighboring state. So they would never take him to our hospital. And so on that phone call, he's tearful, he's endorsing depression and lacking the will to go on living. Due to the TPN and the surgery and the psychosocial issues, and he's also broke at this moment due to all his complex medical care and inability to work. And so when we talk to him about the things that are going on, he has seen our psychologist at the center, but he has his own psychologist outside who this patient reveals will no longer see him because he has not been able to pay for his last several sessions. Next slide, please. So just, a lot to take in here, but I think I've broken down some of the issues: medical non-compliance, a patient with a very complex organic medical condition, chronic pain, distance from provider, inadequate family support, poor psychiatric access for a chronic medical condition, exacerbated by anxiety, depression, and financial strain. So I look forward to that discussion later. Thank you so much.
Thank you, Dr. Chang. We're going to now move to Dr. Hourigan. So I'll let you go ahead and unmute and please give your presentation.
Great, thanks. Hi, everyone. Thanks so much for joining us today. My name is Shannon Hourigan. My pronouns are she, hers. I'm a staff psychologist at Boston Children's Hospital, where I have the pleasure of working at the Center for Advanced Intestinal Rehabilitation, and I'm an instructor in psychiatry at Harvard Medical School. You can advance the slide. So I'm going to bring us back to a pediatric context, as I'm a pediatric psychologist. And I'm going to talk about a few cases and highlight some of the importance for the psychosocial providers who are joining us on the call today to think about some of the different contexts that are experienced by our families, with the hope of sort of highlighting these different issues that are going to be important when you're considering your case conceptualization and how to support these families. So it's really important to understand for folks who haven't, for folks who work with folks with SBS, but also for folks who are new to this area, is that there's an enormously high burden of care for families of kids with short bowel. These are kids who are repeatedly in the hospital. There are lots of increased demands around feeding. There's, frequent outpatient medical visits. Families are having to, maintain clean areas in their homes where they're doing medical preparation. There are lots of behavioral challenges for kids associated with restricted diets, late exposures to foods and textures. There's a lot of parental anxiety. A lot of times parents have been through an extremely stressful course. Sometimes these are families who thought that, they were sort of going to take home a healthy infant, and then something happened. And there's a lot of trauma in the families to be aware of. There are often challenges around toileting and stooling, and all of the things that are really common challenges for families with kids who are more typically developing or don't have these kinds of medical complications. A lot of these issues are really heightened for our families with short bowel. And so it's really important to have a sense of that and assess around those issues to have, to understand. You can go ahead and advance the slide, please. So something to really think about, and I wanted to include some questions here to include in your assessments, and I'll share some clinical tidbits here. So, thinking about who is the child's caregiving team. A lot of kids and families with short bowel have some at-home nursing support, which means that there's a person who comes into the home and helps for some number of hours, and this varies by by coverage, by state, by availability, by lots of different things, by family preference. But oftentimes there's somebody else who's coming into the home in a caregiving capacity, and it's sort of an expert caregiving capacity, who's engaging with the child and the family in some way. It's really important to understand that, even when the issue that you're addressing with the family doesn't seem to exactly necessarily have to do with that provider. So as an example, a while back, I treated a young child, 4-year-old boy with short bowel syndrome, who was struggling with really significant separation anxiety. This is a kiddo who would become completely emotionally dysregulated if his mom, like between the time that his mom closed the car door after buckling him in and walked to the front of the car to get in the driver's seat, would follow mom around, wouldn't let caregivers out of his sight, a lot of distress. Something to think about, something that became really important in understanding how to help treat this family was understanding that the caregiver, who was the at-home nurse, had been with the family for quite a long time, had been enormously supportive, was an incredibly loving caregiver, who cared very deeply for this child and family. The family felt very lucky to have this caregiver. But one of the things that was a challenge is that this caregiver really struggled with seeing this child in any kind of distress. And so the nurse would make all these kinds of accommodations for the child, like holding his hand the entire car ride, right, to the hospital. So it was like a 45-minute car ride, and this caregiver was like twisted all the way around to hold the child's hand, okay, sort of sending the signal to the child that this child's hand must be held, that the child maybe couldn't tolerate, hand not being held on the way to the hospital or something. So understanding that in addition to having two parents, there was somebody else who was an important person in the home, and successful treatment really necessitated working with families, both of the parents as well as that caregiver, to sort of all align and support this child, and learning that these feelings were real, but he could handle them and he could sort of move through. So it's really important to understand there are other families where there's sometimes extended family members involved, grandparents or other extended family members who come to support the complicated care of these families. So just making sure that you're aware of all those things. You can advance the slide, please. It's also important to really be thinking about, when you're formulating a treatment plan, is to understand all of the different ways in which the care requirements for short bowel can really disrupt the family. So for example, awareness about parents' sleep and what sort of additional burdens are being put on the family. Parents are sometimes sleeping in the same bed with kids so that they can attend to pumps that are going off in the middle of the night. Parents are having to get up to change the feeding bags of feeding formula so that kids can get their nutrition overnight. So it's a really important thing to be aware of all the different things that are happening with families, and thinking about treatment and case conceptualization. When you're working with a family where the parent, for example, isn't getting a full night of sleep, then thinking about, asking parents to do something additional at night, or something, getting up, to do something additional in the morning. It's a really important thing to understand, what are the things that what are the struggles that families are having, and being aware to ask about those things so that you can really understand. Because parents of kids with short bowel syndrome, it's their normal. They've been living with these challenges for the entirety of the child's life. And they may not realize that, they may not think to describe, those challenges. You can advance the slide, please.
Thank you so much, Dr. Horrigan, for your presentation.
Thanks.
And we look forward to the discussion with the others. So now we're going to ask Dr. Stellway to give her presentation.
Hello, all. Good morning from the West Coast. So I'm Jacqueline Stellway. Pronouns are she and her. I am a pediatric psychologist at OHSU in Portland, Oregon, in the GI department. Next slide, please. So following this great information that you heard from Dr. Horrigan, I think I'll be able to expand on this a little bit more to speak to some of these specific challenges. As Dr. Horrigan was saying, how we can ask families directly what challenges they're facing, so we can be really thoughtful about that. And so I want to share with you a little bit deeper look at this from a study that was done a couple years ago interviewing parents who have children with short bowel syndrome. And so all of the children whose parents were enrolled in this study, children had short bowel and were undergoing or participating in a multidisciplinary intestinal rehabilitation program. All of the children were between 0 and 5, so little itty bitty ones. And the comparison group for this study was parents who had children with other common GI complaints. And so some of the key takeaways from this study where we were able to ask parents to complete self-report measures and also have detailed interviews with them. And so some key takeaways were that parents who have children with short bowel experience greater symptoms of anxiety and stress related to their parenting role in comparison to the parents from the other group who had common GI complaints. And so further, the short bowel parents experienced a decrease in stress over time, which was really great for us to know. And they adjusted to the daily demands as they found support in their communities and their various systems. It was also wonderful to see the resilience that comes through here as the short bowel parents rated their quality of life similarly to that of the comparison group. And also their self-reports of depressive symptoms and somatic symptoms were similar between the two groups. Next slide, please. And so we had a chance to really dive deep here when interviewing the parents and later coding the interviews and finding themes within the responses. So you can see here the 3 main themes that were identified, and each one has a couple sub-themes. So these themes are probably not surprising to you based on all the information that you've already heard today. Parents had a lot to say about the difficulties of navigating the variety of care needs for their children. So all parents had a lot to say about the complexity of the treatment that they do at home, whether or not they had a home health nurse, including setting up many appointments, all the different therapies, all the medical visits, all the providers that they had to work with. And parents spoke a lot about the challenges of the complex daily care routines. One parent said, "There's no shortcuts. Everything is very involved." And many parents shared stories of their children getting line infections or having to go for long hospital stays after a treatment complication at home. Really, all of this leading to a lot of hypervigilance and worry, understandably. So several parents had home health nurses. And as you'd heard already about some of the wonderful pieces, but also the challenges with this, parents shared that much appreciation for their home health nurses, with a few reporting an increased quality of life having home health nurse. But the piece here that was most important is the consistency. So when a family had a consistent home health nurse, they felt that that increased their trust and it decreased medical complications. But sometimes that's hard for families to find through the different agencies they work with. Parents also found navigating insurance to be a barrier at times. The poor communication from insurance companies, sometimes being told like, we don't have those supplies, we can't get them to you for a long time, and parents ordering a lot out of pocket and having to deal with the challenges of the financial burden there. And so we as a medical team, and specifically as mental health providers, we can advocate for improved quality home care for these families and improved systems around which the medical system is supporting these families. And with regard to the medical team, parents had a lot to say about the challenges of going between so many different providers at times, different specialists, and sometimes specialists who were less familiar with short bowel, specifically when they're inpatient in the hospital, finding that the care teams there were not as familiar with the intestinal rehab program that this family was sticking to. Some families felt that their concerns were not heard or respected, or they were doing different things in the hospital than the family was used to doing at home. And so the takeaway here is the importance for medical teams to diligently coordinate care between all of the different providers that child is seeing and with community providers. And with training in, say, motivational interviewing, empathy and compassion, and shared decision-making, parents will feel more comfortable and supported. And as mental health providers, we're in a really unique situation to be able to support this, being a liaison to facilitate sometimes more effective communication between families and their medical systems. As I had mentioned before, a key takeaway here was the increased anxiety and stress related to parenting a child with short bowel. So there's obviously a lot of parenting stress associated with the complex and chronic medical condition. and specifically the daily care at home, such as TPN. And so in interviews with short bowel parents, it became clear that hypervigilance and fear about the child's health status or possible infections, possible hospitalizations was a key factor in their stress. And this was complicated by the daily treatment regimens and really limited support and limited respite for the parents at times. Several parents commented on how they were told they need to engage in self-care, but they were like, wait, I don't have time for that. Like, sometimes we tell parents you can't pour from an empty glass, but sometimes that's a misdirected comment, as a parent doesn't feel that they even have a system of support around them, that they can maybe leave their child with someone who they trust in order to do that self-care that they want to be able to do. And another piece here is how support people like family members often said that they were too scared to help take care of the child. There's so much complexity to the care that family members didn't feel comfortable. And this creates an avenue that we can better support families too, by inviting them to bring in their support people and be able to train them or help them understand the care during a clinic visit so that they can feel more comfortable and have these people in their lives to help them out. And as a medical system, we can also improve the opportunities families have for evidence-based and reliable and empathetic care. So example, through evidence-based psychological interventions, we can help parents reduce anxiety and the parenting stress that's related to caring for a child with short bowel. Next slide, please. So I want to just very briefly highlight one parent who was interviewed in this study. I will call her Claudia. And she was a young mom in her early 20s who had a toddler with short bowel who was on TPN. And Claudia had a home health nurse or home health nurses who rotated day and night. But at first they were very inconsistent because the agency was just sending different people. And this was really stressful to her. She didn't feel like she really had anyone that she felt comfortable leaving her child with for long periods of time. And over time, she did have consistent nurses. And she came to really trust them. And this was a huge change for her and in feeling that she was able to step away and able to engage in a couple other areas of her life. So Claudia spoke also about her own social relationships, including her family and friends and romantic life. And she found herself losing touch with most of her friends as she had difficulty relating to them. She didn't have a lot of family around, and the child's father was inconsistently around. But she was able to participate in some support groups over time that she felt was really valuable. And she felt that when she was able to relate to other parents, it made her feel a lot more kind of comfortable in what she was doing. So Claudia shared a lot about the internal battle of trying to trust people to watch her child, while also knowing that this complex and critically important, like the specifics of taking care of TPN and some of those other pieces. And she wanted to devote her time and energy to that, but she also found that she needed to balance that with some self-care. And what we had seen from the themes overall is the decrease in stress over time. So Claudia's story was really illustrated this, that as she kind of navigated the system and found the supports that she needed, she did have reduced stress over time. Thank you.
Great. Thank you so much for your presentation. And now we're going to hand it off to Ashley to give her presentation.
Yeah. So I'm Ashley Roberge. I'm a licensed clinical social worker at Boston Children's Hospital. I work with Dr. Horrigan in the Center for Advanced Intestinal Rehabilitation. It's a multidisciplinary program that focuses on rehabbing children with short bowel syndrome. So my goal in this presentation is to focus on schooling. So as you heard Dr. Horrigan and Dr. Stelway explain, our parents with short bowel, our caregivers that take care of children with short bowel syndrome are wearing a lot of different hats. And as such, sometimes it's easy to forget, like, oh yeah, my kid needs to go to school. Can my kid go to school? So I'm going to talk about how, as mental health providers, we can help support that transition. And this doesn't mean you have to be a mental health provider within the hospital system. It can also be if you're working with the family on your own in the community. Next slide, Dr. Kim. So can my child go to school? Of course. If they're medically safe and they get the okay from the medical team, of course they can go to school. It's just, there's a little extra that goes into their care than a typical child going off to school in the morning. But it's important when you're having these conversations with caregivers that you're reminding them of the benefits of going to school, like accessing education in a classroom setting, socializing with peers to show them that even though they may be a little different and come to school with extra accessories like a backpack with a pump in it, you're still a kid. And normalizing the patient's ability to participate in a traditional community setting like going to school. Next slide. So, while the answer is yes, that's going to come with a lot of questions from caregivers. A lot of them have to do with, well, who's going to take care of my kid when they're in school? Because I'm used to being the one that takes care of them. So they may be concerned about a medical event happening, or their child being bullied, or being available to participate in activities. And while we as social workers and mental health providers can validate these concerns and empathize with them, there needs to be concrete action items that help address these concerns. It's really the only way to assure these caregivers that their kids can go to school. Next slide. So, first step. Meet with the family to identify and review their concerns. This is where we're validating and empathizing with the concerns that they have. We want to normalize their concerns and say, hey, you're not the only one that is really concerned about your child going to school with short bowel syndrome. There's a whole community that's faced with this dilemma, but we're here to help support you through it and navigate the system. Then we want to identify the concrete ways the team, the medical team, will support the patient's matriculation. And we want to really empower the family to request a school meeting to start this discussion. You want the family to develop a relationship with the school system and say, this is what the patient will need, and here's how my medical team and support team can help with that. Next slide. So, as a mental health provider, we're always thinking about the child as a whole and not just their medical condition. So we want to think about how we can collaborate on writing a letter of medical necessity that often goes with the nursing orders. So the nursing orders will be all taken care of by the medical team, but there's a lot of ways that we can implement accommodations to help improve the child's quality of life while at school. And as Dr. Duro and Dr. Ching explained with short bowel syndrome, there's a lot of different symptoms that can come up that impacts the ability for the child to go to school and kind of socialize in a typical way. So here's a list of accommodations that you could advocate for in accommodations letter. I'm not going to read through every single one of them, but a lot of them include things like keeping extra clothes in a nurse's office in case they're stained by an accident or a leaking G-tube, making sure that there's frequent bathroom breaks and maybe a private bathroom given the symptoms that often occur with GI issues. And an important one, and of course, I'm sure the medical team will think of this, if they have a central line, avoiding participation in activities that can pose a risk. So this is an opportunity where a mental health provider could really advocate and collaborate with the medical team, whether you're within the system or outside of the system in the community. Next slide. All right. So this is another opportunity for mental health providers to incorporate themselves into supporting the family matriculating the child. You can join an IEP or a 504 meeting. And this is where specifically the 504 plan could come in handy when you're thinking about the medical accommodations that a child would need when they're going to school with short bowel syndrome, advocating for a one-on-one nurse if needed or requested by the caregiver. Dr. Horgan shared how a system is really important when it comes to these kiddos, and including that system in the school is very important in keeping the child safe and also reassuring the parents that they're being cared for. You have the opportunity to educate school staff members. So you can explain to them and help the parents through this conversation and saying, you know, they may accrue more absences compared to the typical child due to appointments or hospitalizations. And also thinking about, okay, maybe a school nurse is not typically seeing a child with short bowel syndrome. So how can we support the school in refreshing their education around caring for a complex child like these kiddos? So perhaps pairing with the medical team and the school nurse and doing a training session to show that, you know, these kids can go to school and we can help support them while they're in school, but do it in a safe way. And then another important point is educating the classroom. So like I said, some parents are concerned about bullying, but there's a lot of age-appropriate ways that you can help navigate this situation. And you can do that either by helping the child kind of lead their own discussion or helping the parents join in the discussion. There's a lot of age-appropriate books that a child could perhaps bring to show and tell. And there's also this really cool toy online that you can use to kind of help a child play around with the different accessories that comes with short bowel syndrome, like a pump or an IV pole or a bag. Just a lot of different ways to get creative with having the discussion, and having discussion early on can really help with destigmatizing all the things our kids are going to school with. Next slide. All right, so the ultimate key for success, definitely empowering our caregivers like we consistently do as mental health providers and medical providers, but also reminding them that they're their child's best advocate and they don't have to do it alone. Even though they're their child's best advocate, we're here to support them and partner with them in having these hard conversations with the school, and that there's concrete ways we can go about doing that. Thank you, Dr. Kim.
Thank you so much, Ashley. And now we're going to hear from Dr. Brandon, and then after Dr. Brandon, we will go to the panel discussion. So for those who are on the call, please type in your questions into the question and answer or into the chat, and we will get to as many of those as we can. So Dr. Brandon.
Thanks very much, Dr. Kim. Hi, everybody. I'm Dr. Claire Brandon. I am a consultation liaison psychiatrist, and I specialize in GI patients in my private practice. I'm also an educator at New York University and the Mount Sinai Hospital. So today, my goal for us is to try to look a little bit at team structure. You've heard a ton about the issues that are going on with short bowel syndrome patients, and to nod to the lack of availability sometimes with mental health in these patients. Just a really, really quick note on billing in case you're encountering some of the issues or trying to navigate that with patients. Next slide, please. So I just want to start off with a quick case example, a patient in the hospital that's well known to the gastrointestinal team, but has never actually seen a psychiatrist in the past, whether in the hospital or outside of the hospital. The patient's had been admitted for about 5 different Crohn's surgeries over the last few years, and now has a diagnosis of short bowel syndrome after a lot of resections. She's struggling with malnutrition, started on TPN, but was also experiencing a lot of anxiety and depression that the nursing staff was seeing often when they were popping in to say hello to the patient, change out TPN bags, and check on the patient. So psychiatry was consulted in the hospital. Next slide, please. So, taking that example and thinking about what we could possibly do with this case, being a consultation liaison psychiatrist is not absolutely necessary. It's not possible to have that in all different settings, but it's worth really exploring and understanding if you're in the mental health part of the team or you get consulted, it's worth knowing what kind of roles the different players can play. So thinking about a psychiatrist, whether it's a CL psychiatrist, or a child psychiatrist in the example of young kid patients who are dealing with short bowel syndrome, we want to just really make sure we have a good diagnostic evaluation. A lot of times medical teams get nervous when they see their patients anxious or depressed or crying even, and it's a really great moment for a psychiatrist or another mental health provider to come in and really figure out what this patient is dealing with, how they feel about themselves, their body, their condition. And get a good understanding of what diagnostics we could probably look at for this patient, whether it's generalized anxiety or an anxiety or depression condition secondary to their medical condition, like a medication is causing this potentially. And that could be a whole nother talk, but thinking about all the drugs and things that do get in the way of our patient's mental health is worth noting and thinking about and consulting with a psychiatrist. We can also get some good treatment recommendations, things that could help the patient really more immediately in the hospital versus what they might recommend for outpatient treatment, therapy, medications, et cetera. And, coordination with the medical team. A few people today have already said coordinating care. We were talking earlier about coordinating care with the family, which is so, so important. And the psychiatrist or mental health team can be a really great asset in doing that. It's also really helpful to coordinate back with the medical team, right? Closing the loop and making sure everybody's on the same page so that everybody knows how to support this patient as we move forward. Next slide, please. So I just want to take a quick aside for diagnostic purposes. In the case of patients who are being seen by a general psychiatrist or another mental health provider, what often happens is we're using the PHQ-9 and the GAD-7. So either the patient health questionnaire for depression, the PHQ-9, that will look at a lot of different examples that are pretty classic in patients who have depression symptoms. But unfortunately, it's a little bit too generic for our patients with short bowel syndrome because, as I've circled here in red, a lot of these symptoms can be happening as a result of their chronic health condition or their short bowel syndrome specifically. So changes in appetite, feeling fatigued, having issues with sleeping, especially if you're in the hospital, right? If you've ever tried to sleep with the beeping noise next to your ear, it's pretty tough to do that. And trouble concentrating and moving very slow or really fidgety. Those symptoms are all really tough to discern from whether this patient is depressed or if this patient is experiencing a medical side effect. So I just want to plug in here and note that it's probably worth thinking that this is a good starting place for screening, but I really want to help you guys understand what would be a better place to start with these patients who are in the hospital. Next slide, please. So I want to introduce you to this scale. If you haven't seen it before, it's called the Hospital Anxiety and Depression Scale. And it's available for everybody. It's free online. You could just search it and find the full scale and full grading process for it. It's a little bit more in depth, but these are actually all the questions and you rank them by, by number with the patient. But these are a lot more particular to what somebody could be experiencing that would be outside of their medical concerns. That would be outside of a physiological response to the patient's, what the patient is experiencing. That would help us really better understand if they're experiencing anxiety and depression as a result of a mental health condition in addition to their medical condition. Next slide. So moving on to the other parties on this team, it works the best in the hospital when we have a really strong structure, right? It's not just the medical doctors on their own. It's not just the psychiatrists on their own. It's also the therapists, the social workers for either psychotherapy, right? So a lot of social workers and psychologists are trained in doing really amazing, excellent psychotherapy. So we need them on our team to try to help get these patients on board with psychotherapy at the very least. And then our other, social workers and therapists can be helpful in brainstorming, follow-up resources, referrals, different ideas that can really help these patients not get lost in the cracks and not be able to struggle following through with getting really good mental health help. Next slide, please. So going back to our case for just a quick second, what actually happened with this patient in the hospital? So I was able to examine her. I was able to see that this patient actually had a depressive disorder, but it was secondary to another medical condition. So from the Crohn's disease, a lot of the inflammation that was going on. She was also struggling with insomnia, and that was separate and outside of being in the hospital. So we really took a look at that. For the treatment part of it, we looked at ways that the patient could not have such an issue with swallowing and absorbing medications. So that's really important for short bowel syndrome patients. We utilize mirtazapine, which comes in a sublingual dissolvable tablet, as well as olanzapine for both antidepressant effects and sleep effects. And psychotherapy, we went down a route of doing a lot of work with acceptance, with toolbox creation of the patient getting better coping skills for her chronic illness. And we were able to find a referral to a psychotherapist that took the patient's insurance outside of the hospital through the Rome Foundation. And I'm going to give you an idea about some of those referrals on the next slide. Next slide, please. So when in doubt, broaden the team, right? More heads together is better than one. And these are just a few snippet places that you could think about for looking for some of those referrals. The Rome Foundation has a whole GI psychology site. You can join them for case discussions as well. The ACLP, or the Academy of Consultation Liaison Psychiatry, is where all the CL psychiatrists can be found and asked for support or find them in your own community. The International Foundation for Gastrointestinal Disorders, they are really supportive of lots of different GI disorders, including short bowel, and they have great resources for patients, for education, for families. And then finally, the Crohn's and Colitis Foundation, we see a lot of patients subsequently dealing with short bowel secondary to Crohn's and colitis surgeries. So those are just a quick starting place. Next slide, please. Now, this is just a really super high level quick primer because it actually is pretty much a mystery to a lot of people, even inside of medicine, even psychiatry, honestly. So if you're looking at patients who are out of network, but you would like to see them and provide care for them in the outpatient setting, there's a few things to think about and to look at. If a patient has out of network benefits, they would find that out from their insurance. You could work with them to tell them some of these codes. So 90792 is a psychiatric consultation. It's like an intake evaluation. 99215 is usually where I'm at with patients that have short bowel syndrome that I'm working with, because it's a pretty high complexity patient. I'm doing a lot of coordination of care, and I'm also making sure that I review all the patient's medications with them. And then I'm also usually doing psychotherapy in those sessions. So that's 90836. And what you have to have is the patient ask the insurance what their deductible is. Once they meet that deductible, what will they pay for these codes specifically? And you can tell the patient your rate, and they can check in with their insurance. And that gives a lot more clarity what the financial burden would be in the case that you weren't in network with their insurance. And I think that's the end of my presentation. Thanks very much, Dr. Kim.
Thank you so much, Dr. Brandon. And so now we're going to open it up for panel discussion as well as question and answer with the audience. So please type in your questions if you have any. We'd love to get through as many as possible. We've received one question already, which is, does anyone have any experience working with child life specialists, CLS, and how they see the role of a CLS being beneficial for patients who have SBS? So if anyone has experience with CLS or child life specialists, if you all could share your experiences, and please be sure to unmute before you speak, panelists.
I have some. So when working on a multidisciplinary team, you're able to incorporate a lot of different roles, and child life specialists have been a great support, especially inpatient. So when it comes to a child with short bowel syndrome being inpatient, they could be in there for a variety of reasons, and it could last like from 48 hours to months, depending on why they're there. And so during that time, there's usually a lot of different providers that they meet. and they may not get to see their typical medical team as consistently as they would on an outpatient basis. So the nice thing about having the child life specialist inpatient is the fact that they can develop a consistent relationship and be a familiar face to a patient, which is incredibly important when it comes to their coping and mental health. Of course, you have the social workers and psychologists there to support, but child life specialists can bring a different role into it by offering age appropriate ways to explain what's going on, offering different hands-on tools and activities to really understand and help the child cope with the experience that they're going through. And then on an outpatient setting, you can kind of replicate that by involving child life specialists in explaining maybe a scan that the child wasn't prepared for, or lab work that can be really challenging. Child life specialists are a great support system in an outpatient setting in helping with those types of things.
Thank you so much, Ashley.
Yeah.
If others have input on child life specialists, please share. Otherwise, we'd like to get to another question, which is for Dr. Chang and the case that you presented. You know, how did your team navigate through some of the challenges that you've outlined? And sort of a corresponding question is, you know, how best can tertiary care or academic medical centers coordinate with either independent practitioners, independent clinicians, private practice folks in the community to just ensure continuity of care as well as care transitions? So, Dr. Chang.
Great. Yeah. So this is obviously a very complex case. We were able to successfully communicate. He actually went to a hospital near his home in Connecticut. We were able to communicate with the hospital there. We, just picking up the phone, I think it wasn't really a systematic improvement or approach there, but to communicate with the emergency room doctors, then the hospitalist that saw him for his PICC line, which was ultimately removed. He was seen by a psychiatrist because of his suicidal ideation while he was there in the hospital. My staff psychologist, which we're very lucky to have on staff with us, also was able to speak with their team. So it was, a team effort, I would say. In terms of his general treatment and barriers to transportation and care and things like that, I do have to say that, thank you, COVID, telemedicine has been, for some parts of this, quite helpful for patients who cannot travel, but that need more intensive monitoring. So we would see him pretty frequently when he would show up, but then also, we're able to get labs at outpatient labs, like, I don't know if I'm allowed to say the names, but anyways, third-party labs. So we could keep an eye on him sort of a little bit more virtually, and then have him come in for his procedures and things like that. One thing that I do think has been helpful is that with the onset of certain electronic medical records, there is some facilitation of sharing, not necessarily his psychiatric records, but his medical care. So the hospital that he did go to in a neighboring state did have access to his records, so they could get a little bit more information that the patient might not get. Or be able to explain as well. But ultimately still, a lot of challenges in terms of his psychiatric care. Our psychologist did reach out to him and provide some opportunities within his state. Each state does have on, I think on certain APA, the American Psychological Association does have lists that you can refer to state by state. And then he was able to find another psychiatrist with the help of our staff.
Thank you so much, Dr. Chang. Question for Dr. Duro, just regarding the structure of your team. Who's involved on your team? who are the members of the team to provide care for patients with SBS? If you could just give us a glimpse of what that looks like.
Sure. So from the outpatient side, it's me. I have residents, of course, that rotated through me as a medical, facilitators as well. But I have a nurse coordinator nowadays that help all the educational care for line ostomies and G-tube clinic and G-tube issues for the patients. She see patients with me as well, and dietitians that where we see together all the patients that have a G-tube but short gut inside this clinic, and the patients more than 2 years old that we transition to blenderized. So all this blenderized diet, all this is also part of the intestinal rehab, like I would say, program that we provide here. Of course, that the inpatient side has been more than 5 years, 7 years that I'm being at Broward. I kind of developed many protocols from the ER to the inpatient side with a team of hospitalists when the patients are admitted inpatient. And the same team that work with me outpatient become then inpatient, right? And myself as a consulting for the hospitalist group. And I have a very close also surgeon that work, a team of surgeons that see the patient as much as I need inpatient, outpatient. They don't see the patient the same day with me in clinic, but we work very close together. And also the social work, I would say, which is crucial. And the and also a program coordinator, which I have in my office. And because of COVID, we lost a little bit the help with the child psychology, which now we are bringing back again with Nova University. We are engaging on having child psychology back.
Great, thank you so much, Dr. Duro. We have a question here for Dr. Brandon, which is how frequently is the HADS assessment tool used in clinics or in the hospital? For what types of patients would you recommend that? So Dr. Brandon, if you could comment.
Yeah, it's a great question. To be honest, I can't quote how often it is used, but I would say it's very much underutilized because we're often, encouraged by our electronic medical records to do the PHQ-2, and then it shifts over to the PHQ-9. And so those are sort of integrated into our medical records, and they're the easiest ones to get to. The HADS is really more of, you have to go to the patient, you have to know that it exists, which is a real downside to it. But I would suggest using it in all patients that are in the hospital that have a chronic medical condition that you're trying to suss out whether or not some of these higher factors for depression are actually due to their medical condition or due to a primary mental health condition. And it has been validated against the PHQ-9 and the G87. So it's just as accurate. You're not losing accuracy. It's not something someone just made up. It's got full accuracy and is consistent to being able to utilize that to make a diagnosis or to inform your diagnosis at least.
Thank you very much. A question for Doctors Horrigan and Stelway around what is one sort of practical tip to be proactive around assessing and evaluating psychosocial distress in patients with SBS. If you could just focus on one thing, what would that be? So if Dr. Horrigan could go first and then followed by Dr. Stelway.
I think one practical tip is sort of go in to a family with an awareness of what the demands are on the caregivers and the child of their medical care and complexity, but go in with a really open mind. And I like to ask families something along the lines of, what are you struggling with right now? Or what are the hardest things for you right now? We may have an idea about what that might be, but oftentimes, I'd say maybe even most of the time, there's something coming up that, that I wasn't aware of, or there's something going on with the family that isn't directly related to the medical illness, but it's maybe tangentially related. So sort of going in with a sort of open question, and letting families know that they can ask you about all sorts of different kinds of things. It doesn't just have to be about their care, can be really helpful. To give you a really full sense of, like they can talk to you about all the different things happening, so you don't get pigeonholed into just a narrow slice of their care overall.
Thank you so much. Dr. Stelway, your thoughts?
Yeah, I think that was an excellent summary, I think one thing to add would be introducing mental health services or like pediatric psychology from the beginning, kind of demystifying and destigmatizing it right from the onset, even if the mental health provider is not engaged in that exact clinic or is not available for a warm handoff at that time. If the medical team kind of brings it up from the very beginning, it kind of allows the family to sit with that, knowing that that's an available resource. And I find that when I'm introduced from the very beginning of care, families are more likely to come back 6 months, a year, maybe 2 years later when they realize, now I'm struggling and would like some help. And I know I was told that this resource was available way back when, at the time of diagnosis or earlier in treatment.
Great. Well, thank you everyone so much for being here, for participating in this program. As we mentioned at the very beginning, this is part 1. We've got part 2 in May, part 3 in June. So please keep an eye out for those announcements. I want to thank the faculty. You'll be hearing from additional faculty as well in May and June. Please be sure to fill out the evaluation and to claim your continuing education credit. And this now concludes our program. So thank you so much for being here.